continue with the second lecture. I don't know why this is not hepatitis. Okay. It's starting with actually a little bit of an overview about what affects the liver. There are those viruses that are very prone, what you call, they have a predilection for the liver, what you call hepatotropic, and those that the other viruses that will affect the liver as part of this of their systemic kind of involvement, in the body. Most common non-hepatotropic viruses that affect the liver, including the CMV, Epstein-Barr virus, the herpes, and the adenovirus. Most hepatotropic viruses are, as you know, the A, B, C, E, Delta. The list is long. I believe it is down now to G. Okay. All right. Now, morphology of viral hepatitis. For the acute hepatitis, the action is in the lobule. So you will see lobular inflammation. You will see what is known as lobular disarray with necrosis of cell. You will see apoptotic bodies that you call the councilman bodies. You will see Kupffer cell hyperplasia, if you recall, from the prior lecture. The cells will start to actually divide to make up for the space lost by the hepatocytes. And that's the main actually kind of presentation. You may see some portal inflammation, but the changes in the lobule will shadow it, will overshadow it. On the other hand, the chronic hepatitis is characterized mainly by predominantly portal inflammation and spilling over the limiting plate into the lobule. Okay, so now you have a contrast between acute versus chronic. Acute is lobular, chronic is going to be mainly portal. Okay, again, there is an extension on both sides, but this is how the main kind of involvement, happens. Now, just knowing actually the histopathology features is not going to be enough. Even the clinical features are not going to be enough because the different types of hepatitis, the hepatotropic viruses share common clinical, common histopathology features. As a result of that, serology becomes very important. Okay, so you need to know what kind of antibodies, at least that has been the mainstay of actually workup of the differential of liver inflammation, viral liver inflammation, viral hepatitis. Now we have the PCR. Now we have molecular tests that could tell you exactly what you have. But even to this day, pretty much around the world, the use of antibodies continue. Okay, so we still do the antibodies, even for hepatitis C. Okay. All right, so why does not the histopathology gives it out? Why doesn't histopathology tell us this is this and this is that? Again, there is a lot of shared feature. The same type of cells, the lymphocytes are what you see in hepatitis B and hepatitis C. So that's not going to help you much. Sure, hepatitis C, you start to see more lymphoid follicles, what looks like a lymphoid follicle because it's very dense kind of chronic inflammatory infiltrate. But that's not really a solid kind of evidence. You may see some steatosis with hepatitis C and not in hepatitis B. But what if the patient that you're examining the biopsy from had or has a liver steatosis? Then that's not going to help you really much in delineating between the two. And now with hepatitis C, you might start to see mild bile duct destruction, what's known as ductopenia. And that may actually, split it a little bit away from hepatitis B, but that will put it in the differential diagnosis with other kind of hepatitis, including biliary type of hepatitis. Okay, so you need more than one clue. You need the clinical as well as the lab workup, the serological workup, as well as the histopathology findings. So hepatitis A is a benign self-limited disease in the vast majority of cases. However, The outcome of hepatitis A is usually much worse if it is superimposed on a chronic condition, such as chronic hepatitis B, such as chronic hepatitis C, such as hemochromatosis, Wilson's disease, any kind of chronic condition that affects the liver will have a very poor outcome if hepatitis A is superimposed on it. Because the hepatitis A viremia is transient, the blood-borne transmission is extremely rare, and as a result of that, it is not a transfusion risk. And as a result of that, we don't even test blood units for hepatitis A viral infection. Hepatitis A only rarely causes fulminant hepatitis, so the fatality rate, the case fatality ratio is about 0.1% and is age dependent. The older the patient, the more likely that he will have adverse outcome. Hepatitis A is spread by ingestion of contaminated water and food, and is shed in the stool for 2 to 3 weeks before and 1 week after the onset of symptoms. So personal contact with an infected person or fecal oral contamination during this period accounts for most cases and explains outbreaks in institutionalized settings. Now, what are the measures for the prevention and management of hepatitis A? Of course, the hygienic practices are very important. Practices related to food cooking and the type of food that you eat. It is known, for example, that certain hepatitis A outbreaks happen as a result of eating certain types of food, of seafood actually, such as oyster. And one of the reasons why was that the case was that the oysters actually were growing near a, believe it or not, near a sewage dump. And this is, believe it or not, happened in the US. So this is, when it comes to hygienic practices, that's very important to follow. In terms of actually, some of the immunization that could be taken, immune serum globulin could be given to persons at high risk for infection, the very young, the very old, or the immunocompromised, after exposure to the virus. There is inactivated virus vaccine that is not given to everybody, but given, for example, before exposure to people who are traveling to endemic areas or very early after exposure. Okay, so please follow me in this graph. Specific antibody against hepatitis A viral infection of the IgM type appears in the blood at the onset of symptoms, constituting a reliable marker of acute infection. That's an important point to be made. The IgM is actually a marker of acute infection of hepatitis A. The IgM response usually begins to decline in a few months and is followed by the appearance of the IgG anti-HAV. The IgG anti-HAV persists for years, perhaps for life, providing protection against reinfection by all strains of hepatitis A virus. All right, so when it comes to the microscopic examination of what you find actually in hepatitis A is going to be, again, lobular kind of picture, lobular disarray, where the plasma cells predominate. And you may also see some perivenular cholestasis as a result of the injured hepatocytes. When does hepatitis A becomes a problem? So for the majority of people, for the 99.99% of people, it is not a problem. It is a self-limiting disease that will go away on its own. But when someone is already having another liver condition, such as hepatitis B or hepatitis D, or, for example, hemochromatosis or Wilson's disease, any kind of other chronic liver disease, Hepatitis, and then there is a superimposed hepatitis A. Hepatitis A may push that patient into decompensation and may literally kill the patient actually as a result of that. So one of the preventive measures that you may actually take in a case of a patient with the chronic liver disease of whatever etiology is to make sure that your patient is immunized against hepatitis. For example, if it's a chronic hepatitis B, make sure that he's immunized against hepatitis A, okay, and make sure that he's taking all precautions so that he does not get, hepatitis C, for example, okay, whatever it is, IV drug abuse, sexual practices. Before, long time before, it was actually in the form of, blood transfusion, all of those stuffs. You can make sure that your patient is as careful as possible. If your patient is chronic hepatitis C, on the other hand, actually you may make sure that your patient is immunized for hepatitis B and also for hepatitis A. And by doing this, you are going to ensure that your patient does not go into decompensation. Okay. All right, now hepatitis B, on the other hand, is a global problem, is a huge problem. 350 million people are carriers of hepatitis B. Believe it or not, this is after the the vaccination, after the mandatory vaccination for hepatitis B that is now worldwide. About 2 billion people were infected with hepatitis B at one point in their life. All right, so it's a huge problem, and a big problem, especially in Southeast Asia, is the vertical transmission. Up to 60%, of transmission to babies from infected mother. Far more than that you see with hepatitis C, for example, vertical transmission. All right. In the US, of course, where do you find it first? You find it in the blood and all other physiologic and pathologic fluids, with the exception of the stool. Okay. So, and this is actually the carrier of, the transmission. This is how transmission happened with hepatitis B. So it's IV drug abuse and protected sexual activity, and that's more homosexual activity than heterosexual activity. Now, when it comes to the hepatitis B virion itself, this is a diagrammatic representation of the genomic structure and the transcribed components of hepatitis B. Now, the innermost circles are actually represent the DNA, forward and reverse strands. So the forward, the 5 to 3, and the 3 to 5 forward and reverse strands, the DNA of the hepatitis B. The lines that are denoted as C, X, P, S, pre-S1, and pre-S2 are actually peptides derived from the virion. The outermost lines are the mRNA that is derived from the DNA. The ones that are here are the mRNA. Okay, now.
Most cases of hepatitis B are subclinical, with about 10% with fulminant hepatitis or chronic disease. Hepatitis B surface antigen appears before the onset of symptoms, peaks during overt disease, and then declines to undetectable level in 3 to 6 months. Hepatitis B E antigen, hepatitis B DNA, and the DNA polymerase of hepatitis B virus appear in the serum soon after hepatitis B surface antigen, and all signify active viral replication. IgM antibodies to the core, that is IgM anti-HBC, becomes detectable in the serum shortly before the onset of symptoms, concurrent with the onset of elevation of serum aminotransferase. Anti-hepatitis surface antibody of the IgG type does not rise until the acute disease is over, and usually is not detected for a few weeks to several months after the disappearance of the hepatitis B surface antigen. Anti-hepatitis B surface antibody may persist for life, conferring protection. Hepatitis B surface antigen appears first, followed shortly by hepatitis E antigen, which disappears with the arrival of the IgM anti-hepatitis C, that is IgM antibodies to the core. Hepatitis B surface antigen is usually lost after 2 months. Persistence of hepatitis B surface antigen indicates persistent infection and likely progression to chronic hepatitis. The carrier state is defined by the presence of hepatitis B surface antigen in the serum for 6 months or longer after initial detection. The presence of hepatitis B surface antigen alone does not necessarily indicate replication of complete virions, and patients may be asymptomatic and without liver damage. In contrast, chronic replication of hepatitis B viral virions is characterized by the persistence of circulating hepatitis B surface antigen, hepatitis B E antigen, and hepatitis B DNA, usually with anti-hepatitis B antibodies to the core antigen, that is anti-HBC antibodies, and occasionally even with anti-hepatitis B surface antibody, what you call quote unquote non-neutralizing antibodies to the surface antigen. In these patients, progressive liver damage may occur.
All right, here are exercises actually to put what you have just listened to in practice. The first exercise is a patient actually who is missing the hepatitis B surface antigen, also missing the core antibody and the surface antibody. This guy is actually never met hepatitis B before, so he is susceptible to infection. He's not a carrier, he's not a chronically infected, but he's susceptible to infection because he does not have any of the antibodies, okay? And he does not have the antigen, so he is not chronically infected. Simply never met hepatitis B before. Now, the next one is going to be in a patient who has hepatitis B surface antigen that is negative right here, but the core antibodies are positive and the surface antibodies are positive. So this is a patient who have met the virus before and now has developed immunity. How do you know that he has developed immunity? Well, the surface antigen are negative and the surface antibody are positive. So that's what you call neutralizing antibody, okay? It neutralizes the surface antigen. The core antibody is always an indication that the patient has been exposed to the actual virus, okay? And obviously, it's gonna linger after a natural infection. Now, the next one is going to be in a patient who has surface antigen that is negative, core antibodies that are negative, and surface antibodies that are positive. This is a patient who is immune due to hepatitis B vaccination. The reason for this is that with hepatitis B vaccination, you give the recombinant protein coat or capsule of the virus. And as a result of that, the antibody that will be made is going to be directed against the surface coat or the surface capsid, and it's not going to be directed against any other components in the virus. So the core antibodies will be negative, okay? And that's a patient that is, or a person who is immune due to vaccination. Now, the next one is going to be a patient who had surface antigen that is positive, core antibody that is positive. When you have the core antibody that is positive, you have to ask yourself, is it due to IgM or IgG? Usually they tell you, is it due to IgM or total? Okay, the total meaning IgG. So they went ahead and did the IgM and the IgM came back positive. But the surface antibody is negative, okay? So here is the interpretation of these lab data. So because the IgM is still positive, so that tells you this is a recent infection, okay? Recent infection, and the person still have the hepatitis B surface antigen, okay? A recent infection, that means he's still within the 6 months period, okay? Now the surface antibody has not appeared yet, okay? That means you have one of two options. Either this patient is going to have surface antibody being made, and that's going to neutralize the surface antigen. Okay. At the same time, the IgM by that time would have switched to IgG class of the core antibodies, which means it will take you back to this, which is a patient who is immune due to natural infection, or actually the patient is not going to develop surface antibody. Okay. And he's going to have actually the switch to IgG. All right. So it's going to be no antibody to the surface, and total is going to be positive. So it is due to the IgG because the IgM is negative, as you can see here, and the surface antigen is going to linger in the blood. So this is a patient who is chronically infected. All right, so what do you see actually when you do a biopsy, if you happen to do a biopsy on a patient with liver disease? What you're going to be finding is actually, again, you're going to be finding a lobular, but as well as a portal and periportal kind of picture. We did mention before in the first lecture that you may see a combination of this. All right, so steatosis is not a feature, but don't really bet your money on it, because if the patient have any degree of steatosis, which is now very, very prevalent because of liver, fatty liver, and because of steatohepatitis, as a result of the, the obesity epidemic, you may not be able to use it as a differentiating feature between the different types of hepatitis. Here's an example actually of a section taken from a patient with hepatitis B. So you can see that, the livers, those scattered hepatocytes have what looks like a foamy kind of cytoplasm, abundant cytoplasm that looks like foam or looks like glass, depending on how you see it. Okay. Now, this is actually where the viral particles are being made. Okay. And that's the hepatitis B surface antigen. The coats are being made here, are accumulating in the cytoplasm of the hepatocytes. You go ahead and do HBs antigen stain, and we do have a stain against the hepatitis B surface antigen, and it's going to light up, as you can see. The brown color is where the hepatitis B surface antigen are. Here's a section from a patient with hepatitis B, and here you can see that the portal triad is affected, and now the portal triad has crossed over the limiting plate and into the lobule. Okay, so now you have lobular as well as portal in hepatitis, which is what you see with patients with hepatitis B. Here's another example of a section taken from hepatitis B patient, and you will see that some of those liver cells, as you know from POD, will, as a result of the viral infection, will go ahead and undergo apoptosis, resulting in what is known as Councilman bodies. So what's the Councilman body? The Councilman body is an apoptotic liver cells, okay? Now, in addition to this, you will see that some of those, so this is the Councilman bodies, those are the actually liver cells that become ballooned as a result of the viral replication that is happening within them, what we call ballooning degeneration. All right, hepatitis C is or was an enigma actually for a long period of time. We used to call it.
This is a diagrammatic.
Sorry about that. Let's go back. So hepatitis C, we used to call it actually non-A, non-B, because we could not really tell what it is. We knew that it was not A, and we knew that it was not B. In order to pin down actually the hepatitis C infection, before we were able to isolate the hepatitis C, we were borrowing, a couple of tests actually from the liver panel, from the liver function panel, and also from the hepatitis B antibody panel. So we used to do the hepatitis B core IgG, okay? So the IgG, the total IgG to the core, and we used to actually also do the ALT. And those actually what we used to call surrogate testing for hepatitis C viral infection. okay? All right, so now non-A, non-B is the leading infectious cause of chronic liver disease in the Western world. And for a good period to come, it will be either number one or number two, depending on how the NASH, the non-alcoholic steatohepatitis fare when it comes to the number of affected individual in the Western world and especially in the US. So there is a reservoir of patients with hepatitis C who are going to continue to go on to develop cirrhosis, okay? And when it comes to the method of transmission of hepatitis C, the most common actually is intravenous drug abuse at 60% in US statistics. About 4 million people have antibodies against HCV. Now, you need to remember that those antibodies are not neutralizing antibodies in the majority of cases. So in the patients who are chronically infected with hepatitis C, you see a combination of the antibodies to the hepatitis C and the RNA virus itself, the RNA genome of the virus itself.
This is a diagrammatic representation of the genomic structure and transcribed components of the hepatitis C virion. Owing to the poor fidelity of the HCV RNA polymerase, circled in red, the virus is inherently unstable, giving rise to multiple genotypes and subtypes. Indeed, within any given patient, HCV circulates as a population of divergent genomes exhibiting a quasi-species distribution. Specifically, over time, several dozen mutant strains can be detected within one individual and mapped as derivative strains of the original HCV strain infecting that individual. The E2 protein of the envelope, also circled in red, is the target of many anti-HCV antibodies, but is also the most variable region of the entire viral genome, enabling emergent virus strains to escape from neutralizing antibodies. This genomic instability and antigenic variability of hepatitis C have seriously hampered efforts to develop an HCV vaccine. So elevated titers of anti-HCV IgG occurring after an active infection do not confer effective immunity. Moreover, hepatitis C virus is able to actively evade the interferon-mediated cellular antiviral response because E2 and NS5A inhibit the interferon-induced double-stranded RNA-activated protein kinase, which is involved in the antiviral response to interferon. A characteristic feature of hepatitis C viral infection, therefore, is repeated bouts of hepatic damage, the result of reactivation of a pre-existing infection or emergence of an endogenous newly mutated strain. Persistent infection and chronic hepatitis C are the hallmark of this viral infection, despite the generally asymptomatic nature of the acute illness. Cirrhosis may develop over 5 to 20 years after the acute infection.
All right, so this is simply going over what you have just heard, right? For those of you who like the text. All right, similar here. All right, here's the risk factor. So when it comes to intravenous drug use, which is the most common, it's actually counted now at 60%, most common. So obviously it is, we know where to look for, epidemics of the hepatitis C virus. In terms of homosexual contact, sex is, will go down to probably around 10 to 15% as a risk factor for the development of hepatitis C. Needle stick and hemodialysis, so a hospital setting in healthcare workers, and also hemodialysis about 10 to 15%. A blood transfusion, now it's becoming incredibly rare because we have actually an antibody test. We have also, most importantly, far more important than the antibody, we have the PCR to look for the presence or absence of infection. All right, and we have also perinatal. Perinatal is very few cases. It's nowhere near what you see, for example, when it comes to hepatitis B. As I mentioned to you, hepatitis B, from an infected mother, it's between 20 to 60%.
Acute hepatitis C viral infection is generally undetected clinically. In contrast to hepatitis B viral infection, the progression to chronic disease with hepatitis C viral infection occurs in the majority of infected individuals, and cirrhosis eventually occurs in approximately 20% of patients with chronic hepatitis C viral infection. As a result, hepatitis C viral infection is one of the leading causes of chronic liver disease in the Western world, as there is a substantial reservoir of individuals at risk for progression to cirrhosis and hepatocellular carcinoma. The incubation period for hepatitis C viral infection ranges from 2 to 26 weeks. Hepatitis C viral RNA is detectable in blood for 1 to 3 weeks, coinciding with elevations in serum transaminases. In symptomatic acute HCV infection, the anti-HCV antibodies are detected in only 50 to 70% of patients. The clinical course of acute HCV hepatitis is milder than that of HBV. Rare cases may be severe and indistinguishable from HAV or HBV hepatitis. In chronic hepatitis C viral infection, circulating HCV RNA persists in many patients despite the presence of neutralizing antibodies, including more than 90% of patients with chronic disease. Consequently, in patients with symptoms of chronic hepatitis, HCV RNA testing must be performed to assess viral replication and to confirm the diagnosis of HCV infection. A clinical feature that is quite characteristic and important of chronic hepatitis C viral infection is episodic elevation in serum transaminases with intervening normal or near normal periods, circled in red.
All right, now regarding the microscopic features of HCV infection, what you have here, like we have just discussed, lymphoid follicles, ductopenia, mild ductopenia, and also steatosis. Of course, none of them is specific for HCV, and you may see it in other conditions as well. This is why it is only part of the diagnosis and not the full, gold standard. Here you have actually an example of a chronic HCV infection, and you will see that this portal tract where everything started resulted in destruction of the bile ducts. There are remnant, there is probably a couple of bile ducts that are still there, but this inflammation actually have extended into the lobule and into the nearby portal tract, resulting in what is known as a bridging necrosis first, because all the cells in their path are going to die. And also that's going to also be replaced by fibrosis, resulting in what's known as bridging fibrosis. That's going to be the starting, step of the formation of the regenerative nodule, turning the liver into an organ that is crisscrossed with fibrous septae resulting in the cirrhosis development. Another example of that, where you see that the cirrhosis now is well established. So when you look at that, you may see actually the presence of this steatosis. You may see also remnants, of what looks like lymphoid follicles here and there, here and here. And if you look in the portal tract, or what was the portal tract at one point in time, you will see that the ducts, the number of ducts, bile ducts have decreased significantly. So there is ductopenia. Though all of those are, what you call non-specific features of chronic hepatitis C. So they are characteristic, but not specific for hepatitis C. When you do the testing for hepatitis C, the first thing that you need to do is the antibody. The antibody is not really going to tell you if the patient is having the infection, the infection or have cleared the infection. Because first, it's going to be there only in about 75% of the time. Even when it is there, when the antibody is there, that does not mean that your patient has cleared the infection. What will decide if your patient has cleared the infection is if you go ahead and do the polymerase, the PCR, the qualitative PCR, to tell you there is a virus or there is no virus. Once you do that test, the next step is going to be the quantitative PCR. And that's going to give you the load of the virus in the patient's blood. Why the load is important? Because that's going to help you decide, that's going to help you to decide the response to treatment by the patient, okay? In addition to this, of course, you will do the liver function test to see how the liver is doing. There are major complications of hepatitis C, including fatigue, cirrhosis, and of course, the hepatocellular carcinoma. All right, now we have hepatitis D. Hepatitis D is a big factor in Southern Europe and in the Middle East, up to 40% of patients actually. Now, this is a defective virus. It will never cause any infection unless there is hepatitis B infection that is there as well, okay? So there are two scenarios for the hepatitis delta or delta Asian, different name, hepatitis D, delta Asian infection, for it to happen. One of them is a co-infection with hepatitis B, for example, the serum containing both viruses, all right? Or actually, there is a superimposed infection, if you will. So the patient already has hepatitis B, and then on top of it, he acquires the hepatitis delta antigen, okay? In terms of risk factor, similar risk factor to what you see with hepatitis B and C. So it's going to be bloodborne, okay? It's going to be bloodborne, it's going to be IV, drug abuse, going to be needles, okay? Sex also is involved, all right? But different scenarios depending on a co-infection versus superinfection. All right, so how about this? 40% in Africa, Middle East, and Southern Europe, Italy and Spain. All right, so how do you tell if you have a recent infection with the Delta Asian? You're going to be looking at the IgM, okay? So the IgM is the most reliable indicator. The same exact thing in other infections. That will tell you that you have a recent infection. So what happens actually when you have a co-infection? So two viruses, the HBV and the HDV are infecting the same patient. What happened is that the hepatitis delta agent need actually the coat, the HBsAg, and also the viral genome, components of the viral genome of hepatitis B for it to be able to replicate, to become active. So as a result of that, there will be competition on this between the two viruses. And weakening of the two viruses, as a result, the most likely scenario is that there will be recovery with immunity because of the weakening of the two viruses here. Now, what happened if there is already, right, supposedly, yeah, so this is the second one. What happened here actually, if you have an already established infection with hepatitis B, okay, right here. So the patient already have hepatitis B, and then he got actually hepatitis D. The likely scenario is going to be actually chronic hepatitis B and the progression of chronic hepatitis in the majority of cases. All right. So difference between co-infection versus super-infection. All right, so now actually what you're looking at, sorry about that. So you're looking at, what happens if there is actually a co-infection of the two viruses that is going to result in the recovery from both of them. The recovery, of course, is going to be denoted by the presence of the IgG to hepatitis B, the surface antibody to the hepatitis B, and of course the core antibody to hepatitis B. The IgG for hepatitis D are short-lived and you will not be able to pick them. So the only thing that you will pick, and only for a short period of time, is the IgM, anti-HDV, okay? So this is what you see with a co-infection, weakening of both viruses, and the result of that is going to be actually the clearing of both viruses and the immunity to both viruses. Why don't you see the IgG? Because like I told you, it has a very short half-life and very unlikely to be picked. What's going to tell you that there was an IgM is going to be the presence, there was in hepatitis delta infection is the presence of the IgM antibody. On the other hand, what you're having here, sorry about that, on the other hand, what you're having here is actually the chronicity of the condition in a case of superinfection. So you already have hepatitis B that is already established, okay? So in this case, you're having the hepatitis B surface antigen that is already there, hepatitis B DNA, and the DNA polymerase is already there, and the E antigen that tells you that you have actually an active replication. And then on top of it comes the hepatitis delta antigen, okay? So in this case, you will be able to find that, there will be a lingering of the RNA of the hepatitis delta that is going to tell you that you do have actually chronic infection with the delta antigen right here, okay? All right, so this is hepatitis C. Now hepatitis E. Hepatitis E is similar in many ways to hepatitis A. Similar in the way that it is transmitted. So it is actually a waterborne and it is oral fecal route. In some countries like India, it is actually more common than hepatitis A. Usually happening during periods of heavy rains, such as monsoons, and that is going to result in sewage overflow. Again, keep in mind the fecal oral route. Now, where is it really? It's a self-limited disease for the majority of patients. It is a serious disease for pregnant females. Okay, keep that in mind. This is a question on many standardized examinations. And in those patients, in pregnant females, the mortality may reach actually up to 40%. There are also a group of other conditions other than viral causes for hepatitis, including bacterial, parasitic, helminthic infections of the liver. Where could it come from? It could be coming from a sepsis, focus. It could be coming actually from the GI, in the form of salmonella. It could be resulting from obstruction to the bile duct, resulting in ascending cholangitis. All right, parasitic in the form of malaria, schistosomiasis, amoeba, and echinococcal granulosis. It could be in the form of helminthic, such as liver flukes, and the favorite, which is Clonorhexis sinensis. Clonorhexis sinensis causes a peculiar form, a peculiar type of bile stones, pigmented bile stones, and we'll talk about that. There may be also pyogenic liver abscesses as a result of unhealed and unresolved infection. Autoimmune hepatitis is a rare condition. So as a result of that, it is a disease of exclusion. You really need to exclude everything. You do all the markers, and all of them are going to be negative. You do IgG, and the patient's IgG will be very high, okay? You do different, antibodies, and you're going to be finding actually autoantibodies against the nucleus, ANA, smooth muscle antigens, autoantibodies, and anti-mitochondrial antibodies. All right, you have a female predominance, like most other autoimmune diseases, and you have actually other autoimmune diseases happening at the same time. There is increased frequency of HLA-B8 and HLA-DRW3. Alcoholic liver disease that's going to present itself with steatosis, alcoholic hepatitis, or alcoholic-related cirrhosis. You will see that those actually phases are interchangeable. Now, a little bit about the toxicity of the alcohol. As you know, the alcohol is a direct mitochondrial toxin. One of the things that are going to result actually from drinking alcohol will be generation of NADH. The excess NADH will have a multitude of effects on metabolism. One of them is that it's going to actually inhibit gluconeogenesis and favor fat deposition. Two, it's going to actually increase oxidative stress. Three, it's going to actually result in mobilizing iron from ferritin, so there is also accumulation of iron. And five, the way for the alcohol also to affect not the NADH but the alcohol itself actually to cause increased toxicity is by simply competing on the P450 detoxifying enzyme from whatever source. If someone actually take Tylenol as a result of because they want to relieve the pain that resulted from the ingestion of alcohol, that Tylenol is going to accumulate and will become actually toxic to the liver cells itself. Many of the autopsies, you see that there is a problem in zone 3 in the liver, the zone that is entrusted with detoxification. Why? Because in those patients who are alcoholic, Tylenol has accumulated because the P450 is busy working on the alcohol. So these are actually the different stages of the alcoholic liver disease. Starting with the steatosis that may actually go on to result in steatohepatitis and may actually eventually end up in cirrhosis. As long as the patient does not get to this stage, everything is reversible. With abstinence, it may go back to normal. Here's an example of a fatty liver. Usually they are huge. So instead of 1.5 kilogram, some of the livers that I used to receive in the pathology suite were like 3.5, 4 kilos, believe it or not, a handful. Here's another example of a large liver, as you can see here, that is, simply, just from looking at it, you realize how big it is. So you will see that increased size and decreased attenuation of the echo coming as a result of the fatty infiltration. Now, fat itself is an abnormal substance, so it will result actually in injury to the liver cells. And the injury to the liver cells will be through simply, the ballooning that will happen, from the steatotic changes in those liver. And it will also happen as a result of the inflammatory response, of the tissue. In this case, it will be in the form of neutrophils. So there will be neutrophilic abscesses that are going to take care of the hepatocytes in those regions, resulting in their death. In addition to those fatty droplets that have accumulated and have resulted in ballooning degeneration of those liver cells. So much so that at one point in time, you will see the accumulation of the biliary hyaline, which is an intermediate filament component that is seen in alcoholic hepatitis. And it's not really diagnostic for alcohol-related disease because you may see it in other conditions. Pinkish/orange in color. This is an example of the liver cirrhosis that result from alcohol abuse. It's known to be actually, at least in the early stages, micronodular cirrhosis. But eventually, those micronodules are going to start to coalesce with each other. Sorry, that will result in the formation of larger nodules. Okay. All right, so what do you find in terms of alcoholic liver disease? Of course, before that, actually, what you have here, this bluish color, is not from the H&E. This is simply trichrome Mason, stain that will stain the fibrous tissue for you to show you how much fibrous tissue there is in this liver. Okay. So what do you have actually in alcoholic liver disease? So you will have the hepatomegaly, hepatosplenomegaly, in those patients. You will see that the spleen may be involved. So there may be also thrombocytopenia. The liver is not working well. So the liver is not really producing any coagulation factor. So a chance of actually bleeding may be there as well, even early on in the course of the disease. Now, what's interesting is that Robbins does mention that jaundice, ascites, even hepatic encephalopathy may happen actually with simply fatty liver, for the very first stage of the process of alcohol injury. So you may see these very dire straits kind of conditions, even with fatty liver. All right, and we may see also macrocytic anemia because, as you know, the liver is the site where the folic acid and the vitamin B12s are stored. And those patients will have such a poor diet that, when it comes to eating greens, they will not be doing that. And at the same time, their liver is busted as a result of the alcohol injury. So you will see first, the folate deficiency, and then eventually, over the long run, you may see also vitamin B12 deficiency, resulting in the long run, in a megaloblastic anemia. In the early stages of the process, you may see actually macrocytic anemia that is not really megaloblastic anemia, which is, a little bit strange probably for most of you. I wonder if you have read that or have heard of that in the heme block. Have you guys? Macrocytic anemia that is not megaloblastic. Have you heard that before?
No.
Have you? I'm not asking Dr. Suhaib. I'm sure Dr. Suhaib has heard about it. But the students, any idea? All right, so what happened here actually, because there is abnormal lipid metabolism, that some of these lipids will find their way to the RBCs. And they will be on the surface of the RBC. And as a result of that, the RBC will look like larger than normal. So at least this is a simple kind of explanation to why you see macrocytic in the absence of megaloblastic anemia. But in the long run, again, as a result of the poor diet and as a result of the injury to the liver, that patient may actually go on to develop a real megaloblastic anemia. All right, what are the causes of death? Usually what you find in other conditions as well. The patient may go into hepatic coma, massive GI hemorrhage, for several reasons. Intercurrent infections, the patient, again, the liver is the powerhouse that makes everything, including immunoglobulin. So, the intercurrent infections may become more frequent during, cirrhosis. And, hepatocellular carcinoma that may actually arise also in a subset of those patients. All right, so do you guys want to stop here a little bit and then continue maybe after 10 minutes? What do you think?
Yes, doctor, please.
Okay, thank you. Words about, even though we did talk about the pathology of portal hypertension and maybe a little bit about ascites as well, but this is actually coming to you courtesy of Robbins, okay? Starting with portal hypertension, we did talk about the obstruction to the portal venous flow. This is one, from the accumulation of the fibrous tissue in the space of DC between the hepatic sinusoids and the hepatic cords. Okay, this is one. Two, remember that actually those cells that make up this accumulation of of fibrous tissue are cells that have myofibroblastic ability. So they are able to contract, okay? So imagine, it's not just fibrous tissue, but fibrous tissue that it has an ability somewhat an ability to contract that will actually cause more insult to injury and more obstruction to the flow of blood into the liver, okay? Now, in addition to this, you are going to start to see that there is anastomosis between the portal system and the systemic, the systemic collaterals, the portosystemic collaterals. That's going to add more pressure into the portal circulation. We did talk also about the non-clearing of the gut bacteria, if you recall. As a result of the slowness of the portal circulation, those gut bacteria are going to result in actually the nitric oxide, formation. Nitric oxide will add more, more flow, more speed of the flow, which is going to add further resistance to the flow and further increase in the pressure in the portal circulation. So this is number one. Number two is going to be, again, also courtesy of Robbins, pathology mechanism of ascites. There are three, at least, theories. It's not really, none of them is like accepted 100%. And a lot of people believe it's a combination of all the above. There is the underfilling theory. So in this one, it tells you that there is sequestration of the fluid in the splanchnic vasculature. All right. And as a result of that, there is decreased effective circulating blood volume, which is going to activate the plasma renin, the aldosterone, and the sympathetic nervous system, resulting in a renal sodium and water retention and ascites formation. The second one is the overflow theory. The overflow theory is exactly the opposite. The overflow theory is, goes hand in hand with the observation that patients with cirrhosis have intravascular hypervolemia rather than hypovolemia. And the result of that is going to be inappropriate, the primary abnormality of this is inappropriate renal retention of sodium and water in the absence of volume depletion. Now, the most recent theory is peripheral arterial vasodilation. This one borrows from both the underfilling and the overflow theory. So in this case, what's going to happen that portal hypertension leads to vasodilation, which causes decreased effective arterial blood volume. Natural history of the disease progresses, neurohormonal excitation will kick in action. More renal sodium is going to be retained and plasma volume expands. That's going to result in increased fluid in the peritoneal cavity and the development of ascites. Now, the last one that I want to discuss with you about here is mechanism of hepatic encephalopathy. All right, you have several factors, if you will, again, theories about how it comes to happen. One of them is actually due to, or at least the presumptive etiology, is due to increased production of reactive oxygen species. All right, the second one is the action of the ammonia, the inflammatory cytokines, on the astrocyte swelling and oxidative stress. And the last one is the formation of what is known as oxidized RNA species. Exactly how it does that, we don't really know, okay? But they are finding actually that there is a potential biochemical explanation for the multiple alterations of neurotransmitter receptor systems and of synaptic plasticity due to the formation of the oxidized RNA species. All right, the reason why I mentioned these three slides for you is because it's important actually, especially on the SAQs, on the short answer questions on the exam. So please make sure that you know them well. Okay, this is number one. We finished this lecture now. I can continue into lecture 3. Hopefully we will not need full hour from 1 to 2, or you may actually have questions and ask now. It's up to you. Hello.
Doctor,
Continue.
I have a question. Can I please ask, because I have Pro 1, 2, 3.
تفضل.
So on slide 57, if you Yes, if you can
Just one
please
second.
go.
Yeah, just 1 second, please. Okay.
No, actually, I think it's the, I don't know why it's different in my presentation. It's the one about the nodules, alcoholic cirrhosis.
Right. Okay, hold on 1 second.
Yes, it's 55, right?
Right.
So here we don't actually see the fatty liver, right? This is all fibrous
Right,
tissue.
because what happened, in the end stages, there would be so much cirrhosis that the fat is going to be extruded. It's gone. It's not really there anymore. Okay, it's the liver in almost all conditions, in almost probably all of the conditions, cirrhotic livers are going to become much smaller than what it was. The larger livers are usually what you find in fatty liver and inflammatory liver. Why is it big? Because inflammation brings in a lot of cells, right? And a lot of edema. And those are going to add weight and size to the liver. Now, what happened as a result of the ongoing insult and injury and fibrosis formation, fibrotic strands formation, and cirrhotic nodule formation, the liver will become a much smaller organ, when it becomes cirrhotic, okay? Regardless really of the cause, across the board, it will become much smaller, version of what it was before, okay?
Yes, doctor, thank you. One last thing. That table that you were talking about with the patients, I think it was slide 18,
Yeah.
the last table on the serological markers in HBV.
Okay.
Right, it's slide 18, yes. Can you please explain this again if you don't mind?
Sure. So in this case, actually, you have a surface antigen that is positive, okay? You have a surface antigen that is positive. Sorry. Sorry about that. All right. So surface antigen that, I'm sorry, I cannot expand it because then I will go back to the same last slide. So surface antigen that is positive. And then you have a core antibody positive. When you have a core antibody positive, the first question you need to ask yourself is core, let me put it to you this way. Core antibody means there is exposure to the virus. Okay? You have to ask yourself, is this a recent core or is this actually an old core, which means is this an IgM or is this an IgG? So you do the IgM. If the IgM is positive, then you know that this is actually a recent core to the antibody to the virus, to the hepatitis virus. Okay. Then you look at the surface antibody. The surface antibody are negative, right? So you are simply actually in the window period, while the surface antigen is still positive, but the surface antibody has not developed yet. Okay. And the IgM to the core are positive. Clearly, you are in the acute phase of the infection. If the hepatitis B, so this is actually acutely infected. If surface antibody eventually, become formed, if they become formed in ample amounts, you will see that the surface antigen becomes negative, which means that the surface antibody have neutralized the antigen, which means now, so the surface antibody will be negative, the surface antibody, I'm sorry, will be positive, surface antigen will be negative, the core antibody will switch from IgM to IgG. You are simply going to go back to this right here. So a core antibody is going to be positive, that's the IgG. Surface antibody will be positive and surface antigen will be negative. So that's immune due to natural infection, okay? Now, on the other hand, if that does not happen, if the surface antibody for whatever reason do not form, which means that the surface antigen will linger, will continue to be there. Beyond 6 months, that's actually a definition of chronically infected. But don't wait for that. You will look at the core antibody and you will do the IgM and it will turn out to be negative. So you're looking at now, it's actually a total IgG that is positive, right? Surface antibody that is negative with a positive surface antigen, that's for sure is a chronically infected patient, okay?
Yes, doctor, thank you.
All right. Anything else? Okay, so let's move on to the last lecture for today. Just one second, let me erase that. Before that, I need to give it to you, of course. Let's do stop sharing now. And then, where is the chat? And then where is this now? Just one second. All right, it's coming now. All right, so now let's see. No, that's not it. Stop sharing. All right, let me close that. All right. All right. Just 1 second, please. I just want to take 1 second away from you. All right. All right. So now we're going to be talking about what's happening. Please don't tell me it's okay. Sorry. All right. We're going to be talking about intrahepatic biliary tract disease. All right. Starting with disorders of intrahepatic bile ducts. All right. We're going to be talking about secondary biliary cirrhosis, primary biliary cirrhosis, and primary sclerosing cholangitis. All right, starting with secondary biliary cirrhosis. So what happened here is that actually, by the name itself, secondary biliary, that means actually the cirrhosis is happening due to the accumulation and the leakage of bile. Bile is a very corrosive substance, far more than, the gastric acid. And if it goes into the liver parenchyma, it's going to destroy it. All right, so it's going to result in its destruction. Now, the most common cause that logically comes to mind is the extrahepatic cholelithiasis. But there is a long list of things that may actually result in that. How about actually a tumor that is arising in the bile tree, common bile duct, for example, in the head of the pancreas. All right, this is what you see in adults. In children, it could be actually that the bile duct is going to end up in a blind pouch. Cystic fibrosis, where all the secretions of the body are so thick that they may become inspissated and they may actually themselves present a mechanical obstruction to the flow of many things, including bile. Choledochal cyst also in children may actually be a cause of that. And there is also a congenital syndrome, congenital paucity of bile duct syndrome could be causing this as well. I don't know what's happening. All right, so what do you have here? You have actually, as a result of the blockade of the flow of bile, the bile will flow back into the liver and is going to come out of the portal triad. It's going to destroy the portal triad and the nearby tissue. So in this case, you will see that the center of the action is going to be in the portal triad. This is where the regeneration will happen, and this is where the fibrosis will happen as well. So you will see portal to portal kind of actually nodule formation, regenerative nodule formation, and fibrosis formation. All right, so you will see that there is going to be, as a result of the destruction of the bile, there will be proliferation of smaller bile ductules and edema. There will be formation of bile lake within the liver. And as a result of the blockade and the stasis that follow, there is a chance of bacterial infection that will result in ascending cholangitis. Here is a liver that is affected with secondary biliary cirrhosis, one of the causes of secondary biliary cirrhosis. In this case, when you try to cut it, it's very gritty to the cut, very hard to the cut. And it does have actually this yellowish / greenish, color to it, which is the color of the bile, okay? You take a section of that and you will see these nodules, these regenerative nodules that are going to form as a result of the cirrhosis that happened, that crisscrossed this liver. Now, we move from secondary, which is far more common, to primary biliary cirrhosis, which is much less common entity, almost presenting with similar gross features. So in this case, actually, the presumptive etiology is unknown. The etiology is unknown. The presumptive etiology is autoimmune in nature. The result of this process is going to be the destruction of small to medium bile ducts, which is going to again result in the accumulation of the bile in higher up, to the obliteration area, and the leakage of this bile into nearby parenchyma, resulting in, again, biliary cirrhosis. All right, so what does get affected is the small to intermediate bile duct. So the postulated theory is that it is an autoimmune trigger, and there is a chronic cholestasis that happen and retention of the toxic substance that are usually excreted in the bile, such as the bile salts and the copper that will flow back into the rest of the parenchyma of the liver. Who is your patient? That's a very important question to ask. It's a middle-aged female, usually 40, 45 years of age, and there is a hepatomegaly during the course of the disease. As the disease progresses and the liver turns into a cirrhotic organ, it becomes actually, this is where the liver decompensation will set in. So this is when you will start to see ascites happening. This is when you start to see hepatic encephalopathy happening. And again, the spider angiomata and the caput medusa are going to be there as well. All right, insidious onset, presenting with fatigue and pruritus. Etiologies are unknown for both. So eventually end-stage liver disease. Major cause of death are liver failure, that's going to be followed by massive variceal hemorrhage and infection. All right. So what do you see in those patients? You will see significant elevation of alkaline phosphatase. Why is that? Because alkaline phosphatase is present in the bile epithelium. The reason why you do GGTP, gamma glutamyl transferase, with the alkaline phosphatase, because you want to ensure that the source of the alkaline phosphatase is that of the bile, and it is not coming from somewhere else. For example, a pregnant female will have the placenta making this, okay? And as you know, also alkaline phosphatase could come from the bone. All right. Now, you will see also elevated AST and ALT. If you recall actually that from the first lecture, that when you look at a patient with a bile kind of etiology to their liver disease, you will see that the major action, the major value, if you will, the most pronounced elevation is going to be in the, of course, alkaline phosphatase and GGTP. But AST and ALT will also be affected. Why? Because the bile is flowing back into the liver, destroying liver cells. Those liver cells are going to release the AST and ALT, and that's going to show up actually in the blood as well. There will be increased level of cholesterol and lipids, and the hallmark of this disease is the presence of the AMA, the anti-mitochondrial antibody, in the sera of those patients. Okay? All right, so keep that in mind, AMA and PBC. Now, what do you see in terms of morphology? An important actually feature you see is the non-caseating granuloma that are surrounding and infiltrating the interlobular bile ducts and destroying them in the process. All right, the end result is going to be, again, fibrous septae that are heavily loaded with bile. So this is why they take the yellowish and greenish color, resulting in actually the appearance of biliary cirrhosis, the characteristic appearance of biliary cirrhosis. Here is this poor, duct that is surrounded with this granulomatous kind of inflammation. So what do you see with the granulomatous inflammation? You will see, if you guys recall, you will see the chronic inflammatory cells as well as the epithelioid histiocytes. So this process is surrounding and destroying, actually breaching through this poor duct, eventually obliterating it. So much so that in the end, you will see ductopenia far more than what you see in hepatitis C. If you recall in hepatitis C, there is mild loss of bile ductules, but here it is far more than that because the process is centered around actually those ducts. And here you see that the process has started in one portal triad and extended into a second portal triad, and eventually actually bridged over what you call bridging necrosis. You call it bridging necrosis because it's killing all the hepatocyte on its way. Eventually, it is going to give place to fibrous tissue, what you call the bridging fibrosis, and the end result is going to be the formation of a regenerative nodule and the formation of what is known as bile cirrhosis. In this case, it is primary bile cirrhosis. Why? Because we are not 100% sure actually about the etiology. We know it is autoimmune in nature because everything actually points that way, from the presence of the autoantibody, the presence of the inflammatory infiltrate, in the form of a granulomatous inflammation, the fact that it is a female that gets affected, which is more common, where you see, more autoimmune disease, more commonly autoimmune disease seen in females than males. So all the above actually, and the fact that you don't really have anything else. It's a pretty rare disease compared to secondary biliary cirrhosis. So in many ways, it is a diagnosis of exclusion. All the markers will be absent. All the viral markers will be absent. And that's going to lead you towards actually, a primary biliary cirrhosis. All right, now the second entity that we're going to be discussing today in form of a primary process resulting in primary biliary cirrhosis is what is known as primary sclerosing cholangitis. Now that's a very unique condition. Why? Because it is associated with other primary sclerosing conditions throughout the body. Could you guys think about any other primary sclerosing condition? Anything else that is called also primary sclerosing this and primary sclerosing that? Where else do you see it? I will take only one.
Systemic sclerosis.
Sorry?
Systemic sclerosis.
No.
Scleroderma?
Scleroderma, primary sclerosing? I don't think so. I really never read it, but that's not what I was thinking about. How about primary sclerosing thyroiditis? Is there such a thing? Absolutely. All right. There is a primary sclerosing peritonitis, what's known as Ormond's disease. All right. So primary sclerosing thyroiditis, what's known as Riddle's disease or Riddle's thyroiditis, and primary sclerosing peritonitis. There is also primary sclerosing mediastinitis. So these conditions happen in cahoot with each other, with each other. You know what I'm saying? So similar to what you see with other autoimmune diseases, where type 1 diabetes happen in patients with vitiligo, patients with Hashimoto's, right? So the same thing here. Primary sclerosing, always keep that. That was a question on my board exam, believe it or not. All right, so what you have here actually is that those ducts are being obliterated by a, what you call an onion skin appearing fibrous bands that are going to surround those ducts, compressing it and destroying it in the process. Okay, so one very important feature for primary sclerosing cholangitis is what I just told you, the association with other primary sclerosing conditions. Okay, this is one. That will be a question on your exam. How about that? Second very important actually feature is the association with inflammatory bowel disease, especially ulcerative colitis. Keep that in mind very well, because that was also a question on many exams, on standardized examinations. So ulcerative colitis and PSC going hand in hand. Who is your patient? Another important feature. It is a male actually. And in the third to 5th decade of life, so slightly earlier than the PBC. So what do you have here? You have this fibrosis that has this concentric rings surrounding the ducts, eventually destroying it, eventually atrophying it and then destroying it altogether. What happens as a result of that? So there's now obstruction to the flow of bile. The bile is going to flow reverse into the liver parenchyma, creating bile lakes and starting to destroy actually liver, first the portal triad and then the nearby liver parenchyma, resulting eventually in the formation of what is known as biliary cirrhosis. Who are your patients? Two kinds of patients, either someone who's presenting with an isolated elevation of alkaline phosphatase, okay? And the second one is patients who's coming in with symptoms of chronic liver disease. So both of them, again, in your serum alkaline phosphatase. So now you can tell actually that alkaline phosphatase is a marker of obstructive biliary disease. Why is it going to increase? Because it is in the bile epithelium. So as a result of that, you need to assess it if you have any suspicion that this is actually, a bile duct disease. All right, let's see. All right, so here is actually a beautiful picture, courtesy of Robbins, of this concentric rings of fibrosis that are surrounding this poor ducts, eventually constricting it, atrophying it, and then killing it completely, resulting in its obliteration and the obstruction to the flow of bile. Here's a beautiful picture of trichrome stain, where that stains actually the fibrous tissue, and within the portal triad, you will see this concentric, again, rings of fibrosis surrounding those actually the bile ducts and obliterating them and killing them altogether. Of course, this patient is more advanced, than here. What you have here, you have actually cirrhosis because you can see the presence of cirrhotic nodule. So again, like when it comes to primary biliary cirrhosis, primary sclerosing cholangitis, any biliary cirrhosis really in general, you will see that the formation of the regenerative nodule is going to open the door for hepatocellular carcinoma. Why? Because again, you no longer have the normal architecture of the liver, so you have several layers of hepatic cords that will have to die. Why? Because it does not have access to the liver, to the liver sinusoid, to the hepatic sinusoids, does not have any access to oxygen and nutrients, and the end result will be its demise, and then stem cells will give rise to regeneration. This increased replicative cycle is going to actually, or may open the door for a mutation that may result in tumor development. Now, the other reason that may result in tumor development is the brisk inflammatory activity that is still going on in all those conditions that are accompanied with cirrhosis. So chronic inflammation, as you know, is a pre-neoplastic condition, okay? So a couple of things that are going to result in hepatocellular carcinoma development in those patients. All right, we're also going to be talking about actually a couple of systemic disorders that affect the liver like they affect other conditions, including primary hemochromatosis. Pay attention to the fact that this is the primary form of the disease, as opposed to secondary, even though it's called secondary hemochromatosis, but that's really actually what you call a misnomer. Better to be called hemosiderosis, the other form, which results from the transfusion, excessive transfusion in patients who are transfusion dependent, such as those patients with thalassemia who are life dependent on transfusion. All right. In this case, in the primary form of the disease, the primary hemochromatosis is a genetic disease. So now you have to guess actually that the amount of iron that's going to get deposited in the liver will far exceed that what you see in hemosiderosis, okay, in transfusion-related hemosiderosis. Here you have a problem actually with one gene known as the HFE gene, a gene that is held on the short arm of chromosome 6. So what you have here actually is that this gene is mutated. And as a result of that, it's a sensor gene. As a result of that, it it keeps sensing low systemic iron levels. And as a result of that, there are upregulation of iron absorptive proteins. And as a result of that, there will be absorption of so much protein. And this so much protein is going to be deposited pretty much all over the body. Most common mutation affecting this gene is a missense mutation, the C282Y. Make sure you know that. So what's gonna happen as a result of that? So this iron that is getting actually accumulated is going to get deposited everywhere. It's gonna get deposited in the skin, and as a result of that, you will start to see that those patients affected will have a bronze skin. So you may see someone in an office, or in a professional place being, receiving, a commendation, telling them congratulations on your new tan, not knowing that this guy is unfortunately carrying a deadly disease. Again, not everything that shines is gold, as you know. So a tan in the skin, it may actually get deposited in the liver, and when it gets deposited in the liver, like all toxic substance, it's going to actually result in destruction of liver cells and then regeneration of liver cells. That's going to result in cirrhosis of that liver affected with this process. It may actually get deposited in the pancreas, resulting in diabetes mellitus. It may get deposited in the heart, resulting in a restrictive form of cardiomyopathy. So this kind of question makes really for a nice question on any exam. Why? Because it's a systemic kind of presentation. In addition to the fact that it is actually a liver, a majorly liver condition as well. So where does the liver get deposited first? First, it's going to get deposited in the periportal hepatocytes, and then it spreads to actually zone 3. All right. Now, what's the gold standard? There's a long list of tests that you may do, but your gold standard is going to be to do a biopsy of the liver and send it to the chemical lab to establish how much iron you have per 1 gram of dry weight of liver tissue. Okay. And you have that here. How do you treat it? Phlebotomy. Okay. Here is the intense. Usually they mark it as +1, +2, +3. This is +4 probably. The highest, it's inundating really this liver with this process. This is a liver that is cirrhotic from the hemochromatosis. This is a regenerative nodule, of this liver that is actually resulting from hemochromatosis. And you can hear, the Prussian blue is going to give out the etiology of what caused that cirrhosis. And that etiology in this case is the deposition of iron, as you can see here, resulting in the injury and resulting in the fibrosis, as I mentioned to you. All right, now the second disease that I want to discuss with you is Wilson's disease. So Wilson's disease is a mutation of the ATP7B gene. So what is that? That's actually a transmembrane copper transporting protein. So as a result of that, this protein that is responsible for moving the copper from the liver cells into the lumen of the bile canaliculi is mutated, is missing. And as a result of that, there will be accumulation of copper into toxic levels. So copper is going to result in accumulation of these liver cells. These liver cells will die, and the end result is going to be liver cirrhosis. Now, the accumulation of this liver is going to actually not be limited, the accumulation of the copper, will not be limited to the liver. It will start to, again, accumulate everywhere else, including the CNS. So you have neuropsychiatric symptoms in the form of Parkinsonism, and also in the eye in the form of what's known as Kaiser-Fleischer ring. All right, so what do you need for diagnosis? You have to suspect it in any child with liver problems, okay? And as the fact that it is a rare condition, after you rule out the most common conditions, you need to actually go ahead and work up a patient who's an adult for Wilson's disease by sending him again. You do the preliminary test, for example, the ceruloplasmin, which is a transporter protein for the copper, is going to be decreased because you have so much of it now. The amount of copper in the urine is going to be also increased. You do a rhodamine stain on liver biopsy, it will be positive, but again, gold standard is going to be sending a liver biopsy to the chemical lab to look how much, of copper you have in 1 gram of dry liver weight, okay? Clinical features is going to be the Parkinsonism, so movement disorders, tremor, rigid dystonia, rigidity, mask-like features, drooling, and dysarthria, stuff that you have seen actually in year 2 neuroscience. So the Parkinson, not the Parkinson's disease, the Parkinsonism. So those actually, amounts of copper are going to be accumulating, in CNS regions, resulting in this kind of presentation. Kaiser-Fleischer rings, and you may see also some psychiatric kind of presentation, including depression and compulsive behavior. Again, what is the diagnosis? That's going to be your dry liver weight, of copper, treatment, early chelation therapy. This is the Kaiser-Fleischer ring, the brownish actually peripheral accumulation of the copper. And then finally, this is a patient with Wilson's disease, and those patients are going to actually present with what looks like lymphoid follicles again, okay, in addition to the presence of, steatosis. So the patient is not really in the final stages. You start to see some bridging necrosis. Someone asked, what happens to the fat tissue in a steatotic liver? It will be gotten rid of, because with the amount of fibrous tissue that is growing, all the fat is going to be extruded and pushed out, and the end result is going to be a much more solid organ, a much more smaller organ, and much less weight than what you have seen in the inflamed liver, such as what you see here. Okay. This is it. In case you have any question, you may raise your voice. Hello? Did I lose everybody? All right, guys, one thing, there is no reason for the lecture from 1 to 2, because I think you can tell. I think I'm exhausted and you're exhausted. I have to say this to you, why actually the lectures were given today. I don't usually do 3 lectures in one day, and very, very unusual, at least at Al Faisal. I did it because of the simple reason, there were lectures for Dr. Imad Raddawi on Thursday, okay? And Dr. Imad on Thursday is in the hospital. So I needed to prepone his lectures and put them on in the middle of the week and give him practically my time. And I could not actually put my lectures on Thursday. Why? Because, as you know, pathology should be first, and then that's going to be followed by clinical. You cannot do it the other way around. So the only time I could do it is now, actually, okay, is today. And this is the reason why it was given today. So my apologies to all of you, because, there is 3 lectures, that were given today, but I think it was not so bad, really, I think it was okay. It's not really that heavy. Pathology, as you know, is probably the easiest thing that you're studying now in any block, really. Any question? I understand I received some complaints about, from you regarding the number of sessions, and I agree with you. It is, especially now it's getting to the end, it is a lot. But, one question I have for you, where do you put the liver? If you don't put it here, where do you put it? Where do you put the pancreas if you don't put it in, the final week? We go through this, week by week. It used to be 7 weeks. This year it's 6 weeks. And, that's unfortunately will reflect back on how much time, the block in general has, Also, I was asked about, to ask Dr. Weil about his talk to you regarding the lecture, the number of lectures. I will ask him that on your behalf when I see him today or tomorrow, inshallah. What else? The exam questions, the exam questions are not really that hard. You know, I'm receiving your average kind of, you know, questions. I think the difficulty, as you know, will be from the fact that this is a big plot. So my suggestion to you is to sit down and read, you know, and I think you will make it with flying colors, inshallah. All right, final time, I will ask you if you need anything. If not, I will be on my way out. Again, no lecture today from 1 to 2. And thank you for listening.
Will it be rescheduled this week?
Sorry?
Will it be rescheduled this week?
Am I what not going to be in the schedule? Say it again.
The 1 to
sorry.
2 lecture.
The 1 to 2 was actually, I thought that I will need 4 hours, you see? I did not really anticipate that I will finish earlier. There is one lecture, bile duct, but this is not the time actually to take it. It has to be given in the right place. I believe it's going to be given probably early next week, okay? I will let you know when, you know, it's going to be given then. It's a short lecture, it's not long.
Okay, and one more thing. I just wanted to, for the bridging necrosis, bridging necrosis for cirrhosis.
No.
Is it the first step in the cirrhosis? Is it before the regenerative nodule and
yes, of course. Yes.
It's more that lower fibrosis, the fibrotic.
Right. Sure. Let me actually probably, you know, go back a little bit. So the first thing is going to be what you call the triaditis, inflammation of the portal triad. Okay, and then this is going to spill over into the lobule, you know, over the, you know, limiting plate, if you still recall. And when it's split, when it goes into the lobule, it's going to actually, you know, open its road towards, you know, in the tissue. When it reaches, you know, the other portal triad, probably the other portal triad is doing the same, is having portal triaditis, and then is spilling over into the lobule, extending also an arm towards the advancing inflammation from the other portal triad. When they meet, that's going to be what you call bridging fibrosis. That will heal into bridging, that's going to be bridging necrosis. When it heals, it will heal into bridging fibrosis. When this, you know, bridging fibrosis becomes from all sides, that's going to result in the formation of a nodule. Inside the nodule are those, you know, hepatocytes that keep, you know, dying and, you know, coming back again to life, what's called regenerating nodule. This is how cirrhosis eventually comes to happen.
Okay, and one last thing. Is the myofibroblastic activity coming from the stellate cell or the Kupffer cell?
I believe from the stellate cell. As far as I recall, it's the stellate cell, which is a form of myofibroblastic cell. Kupffer cells, I don't believe Kupffer cells are myofibroblastic.
Yeah, they're macrophages, but you said they secrete the cytokines, so I was guessing.
Well, Kupffer cells are actually, if you think about it, are the maestro really of the whole process of liver inflammation. Exactly. They receive all the input, but when it comes to the contraction, you know, process, it has to happen with the myofibroblastic cells. In this case, it is the ito cells. Okay, and the ito cells also, I believe, are the site of the storage of one of the vitamins, right? Which vitamin is that? Do you guys know?
Vitamin A.
Vitamin A, that's right. All right, so that's it. Anything else?
Okay, thank you, doctor.
Thank you very much. Thank you, Dr. Suhaib. I really appreciate that.
Thank you, doctor. There are no questions in the chat, doctor. Thanks so much.
Thanks a lot. Take care.